Welcome to Clear Answers About Clear Vision, the exclusive podcast series by Vance Thompson Vision. Our goal is to empower you with the knowledge and insights to make informed decisions about your eye care. Whether you're exploring options for vision correction, cataract surgery, myopia control, or oculoplastics, we're here to guide you. This podcast is dedicated to helping you achieve clear vision, one episode at a time.
Hey everybody, welcome to another episode. So glad you're spending time with us. I'm Mike Greenwood. I'm a surgeon up in Fargo, North Dakota. I've got two wonderful guests with me today, and I'll let them introduce themselves. I'll start with Kristen.
Hi, everyone. So I'm Kristen Moore. I'm one of the optometrists here at our Sioux Falls location in South Dakota.
And I'm Daniel Trevine. I'm an ophthalmologist who specializes in cataract, cornea, glaucoma, and refractive surgery. I am also in Sioux Falls, South Dakota, and I'm excited about our talk today.
This will be great. So today we're taking a pivot and we're going to look beyond LASIK and we're going to talk about other types of refractive surgery. For those of you watching, hand up if you've had refractive surgery. My hand is up. Daniel's hand is up. Kristen has perfect eyes. No need for her to have refractive surgery. So I had an alternative to LASIK. Daniel, I forget if you had LASIK.
Okay. LASIK.
So we're going to talk a little bit today about, like I said, other types of refractive surgery. So when you say refractive surgery, usually we're talking about LASIK, but if you didn't know, there are other options. You've heard us talk about them: PRK, SMILE, ICLs, refractive lens exchanges, and we'll get into that. And so, Kristen, maybe I'll start with you. When a patient comes in and they say, hey, I'm interested in LASIK, again, we view it as refractive surgery, but what are some of the things that you're looking for on testing or exam that helps you kind of rule in, rule out candidates for refractive surgery?
Yeah, so a couple things that we look at. We obviously get a pretty comprehensive imaging of their anterior segment, so their cornea, essentially the window of the eye. We want to make sure is thick and healthy. There's no irregular areas that would contraindicate LASIK or be a reason that we could not do LASIK. We also want to look a lot into their demographics, so patient's age, their prescription, how high their prescription is. Are they farsighted? Are they nearsighted? Astigmatism, how much is there? And then a lot of behavioral factors I also ask. So what do you do for work? Are you, what kind of environment are you in? Are you at a desk job? Are you a farmer where you're sitting out, where you're outside a lot, spend a lot of time outdoors? A specific question I like to ask every patient is, are you an eye rubber? And we can kind of talk about why that's important too. And then also super important is if they're having any symptoms of eye irritation or dry eye, or are their eyes comfortable and they're just motivated to get out of the nuisance of putting contacts in and out every day, or not being as dependent on glasses.
Yeah. Daniel, what do you want to add?
Yeah, and generally people who, come in and are good candidate, want to get out of glasses and their things are pretty good and they think, oh, I'd love to have LASIK. Really, there's two main reasons they can't have it. When someone has a prescription, we're flattening their cornea typically. We're removing tissue. And if your cornea can't handle the amount of tissue removing, they are typically not a candidate. And there's two reasons. Typically, their cornea is too thin for their amount of prescription, or their cornea is too flat or too steep for the amount of prescription. And so if patients say, man, I don't have dry eye, I really want to get out of glasses and contact lenses, I'm not an eye rubber, I meet kind of all those soft things that Kristen talked about. Even if they meet those, if their cornea can't handle the amount of thinning that comes from LASIK and it would weaken it too much, then we talk about other options for them. And we have great other options. And so usually people are excited to hear about those other options.
Yeah. And kind of the take home from this is there's nothing you can really know, as a patient listening to this, that is kind of going to tell you like, oh, am I a good candidate or not a good candidate, outside of like the lifestyle things like that. But the testing and stuff we need to do is pretty high tech, but it's pretty easy. You stick your face forward, we take a picture, we analyze it, and then we can kind of help give you the different options that will work best for you. And a lot of times, you're a good candidate for multiple of them, but you're a best candidate for something else. And that's where, we can give our recommendation on what would be best for you and your lifestyle and what you're seeking. So that's kind of the broad umbrella where this comes into play. And so we'll kind of focus on these ICLs we talked about, and then the refractive lens exchange part of it. And so, Daniel, maybe I'll start with you. Can you tell me a little bit about what an ICL is?
Yeah, so let's say you really want to get at glasses. You've got a high prescription. You're, let's say, a -5 or a -6, and your cornea can't handle that amount of removal. Then we talk to you about the next option for people, and typically that's what's called an ICL, or an implantable Collamer lens. Some people call it an implantable contact lens because it kind of reminds them of an implantable contact lens. And that's essentially what it is. It's a soft, flexible, foldable lens that sits inside your eye behind the colored part of your eye. And that lens takes care of your entire glasses prescription. And so if you think of your glasses prescription, you place that glasses prescription inside the eye. It doesn't move around. It's perfectly centered. It doesn't get foggy or get dirty. And it's in the perfect part of your eye that gives people the best vision. And so that is what an ICL is. And the procedure is really relatively straightforward for it. We take 5 to 6 minutes for the surgery, depending on the situation. And it's a single incision that the lens goes through, and that lens expands kind of in the perfect position. It gets rolled up. And typically people are really seeing good and feeling good the next day. So it's like LASIK-like recovery time and LASIK-like vision afterwards. And people are typically really pleased with the results.
Yeah, I'm an ICL person, I guess. I've had it done, and you described it perfectly. Kristen, you want to talk a little bit about some of the things we need to look out for with people in ICLs?
Certainly. So there are certain contraindications with ICLs. So when we get all those fun scans of the eye that we talked about earlier, we're looking very specifically at the length of the eye and certain structures that we can ensure when the surgeon's doing the surgery, they have enough room. So in patients who have a far-sighted prescription, or hyperopic is the term that we use, that it would be something that at this point in time we are unable to use an ICL for, partially due to the length of the eye not having maybe enough room for the surgeon. And at this point in time, that's just not something that we would be able to do surgically. It's not FDA approved for hyperopia. Another thing we look at is age. So if someone is close to, getting interested in having glasses independence, but maybe they're 60, that also is going to depend on if we recommend an ICL for them. Likely we are not going to. So if their natural lens is also reaching a point where they're close to needing cataract surgery, we'd also probably steer them away from an ICL in that instance as well.
Yeah. And so, the ICL basically is indicated from -3 all the way up to -20. And it goes up to -15. We can do LASIK touch-up for that last little bit if we need to. And so it doesn't correct the plus prescriptions, but it does correct astigmatism, and that's a relatively recent advancement. When I had mine done back in 2015, it didn't have the central hole, so we had to make peripheral iridotomies or holes in the colored part of the eye, and we couldn't correct astigmatism, and we can do both of those things now with the ICL. So it really is great. And on the surgical side, Daniel mentioned the procedure. It is relatively straightforward. Obviously, it's delicate. Inside the eye is a small space, but these lenses come in small, medium, large, and extra large. So we find the right fit for you. And one of the hardest parts of the surgery is finding the right size for the patient. But AI, artificial intelligence, has really helped kind of make that a lot easier for us to do. And so that's, ICLs in 5 minutes for you guys. Now let's switch gears to what you talked about with, maybe someone who's a little bit on the older side, Kristen, with refractive lens exchange, or RLE. Tell us a little bit about an RLE.
Yeah, so refractive lens exchange, or RLE, is the acronym for that. That's referring to essentially an early cataract surgery. So with that procedure, patients are likely later in age, a little bit older. And so they're also looking for that independence, not just from glasses for distance, but a lot of these patients are also entering or have already entered the stage where they need a bifocal or they need some sort of cheater or reader to help them up close. Not necessarily, but most of the time they're entering what we call the presbyopic stage, so mid to late 40s, early 50s. And for that procedure, we're essentially, like we said, doing an early cataract surgery. So removing the clear lens inside the eye before it turns cloudy and replacing it with a lens implant that can correct for distance, near, or both, based on patient's goals.
Yeah. Daniel, what do you want to add on some of the pluses and minuses with RLE, or what are the things that you're looking out for?
Yeah, and so we've got, basically our three groups of patients here. We've got our patients less than 45 who want typically good distance vision. Their near vision is still okay without glasses. They can, accommodate to see things up close. And if they're great candidates for LASIK, a lot of times people choose LASIK. If they're not great candidates for LASIK, they typically choose ICL. Then we've got patients that are 45 to 60 years old before that cataract or cloudiness of the lens has developed. And typically those people want good distance vision and good near vision, because the loss of the flexibility of their lens has made it so they need to have two things corrected. And that's where RLE comes in. And so talking to people about their lifestyle goals, what they like to do for fun, if they do a lot of night driving, what some of their hobbies are, if they're still working, if they do have any nighttime glare or anything like that, or anything that could signal that a cataract has maybe started. But anytime someone has started to use cheaters or need up close vision help with bifocals or something else, then it's time that we start to switch the narrative to more maybe that refractive lens exchange, which is a better option. And those lenses help give people good distance, intermediate, and near vision. Their eyes shouldn't change much for the rest of their life, and it prevents a cataract from forming. So it's kind of that one point in time where you can take care of all of their glass needs, usually for the rest of that patient's life. And so it's kind of a good opportunity for most people to get that treated.
Yeah. And we talked with, the ICL, where it can only help with the minus glasses prescriptions, and it only helps people get better distance vision. Because again, like you mentioned, Daniel, the patients that are having ICLs, they still can accommodate, they can still see up close without the need for reading glasses, when they have that procedure. Now, when I get into, presbyopic age, not there yet, I might need reading glasses on top of my ICLs, or maybe I work towards an RLE. With a RLE, refractive lens exchange, their glasses prescription doesn't really matter. We can help with plus glasses prescription, minus glasses prescription, astigmatism correction at that same time. And Daniel or Kristen, have you guys done RLE in anyone who maybe doesn't wear glasses for their distance needs, but they're sick of the readers? Kristen's nodding.
Yeah, I think that's becoming more and more common. Someone who maybe had LASIK when they were, or someone like you who had LASIK when they were in their 20s, and their distance vision was amazing, but now they're 50 or 60 and they're starting to need a lot more, they're needing a lot more cheaters, and they want to go back to that glasses independence that they had. And so that's a really common patient that we see.
Yeah, and with the lens technology that's available now, again, these are the same lenses we're using for cataract surgery. The optical quality and the range of these lenses just keeps getting better and better. It's probably true, but it's been about 10 years that ophthalmology is the second fastest changing field in medicine, only behind oncology, with all the technology that's coming out. And it seems like at least every 6 months, there's a new lens that's coming out that's sometimes a major improvement, a lot of times minor improvements, but even these minor incremental improvements are getting better and better, where, I'm 10 years into practice, and about 11 or 12 years ago, our multifocal lenses were bifocals, and you had to be really selective in who you used them for. And now we're using them in people that basically see well without glasses and distance, but they need help up close, and we can, restore that for them with good distance, intermediate, and near. And for those listening, distance vision is basically anything past, arm's length. Intermediate is arm's length, computer work, things like that. Near work is your cell phone and different things that you're looking at up close, reading, stuff like that. So we talked about, ICL, RLE, historically LASIK and PRK kind of in the same boat, as well as SMILE. Let's kind of put this in a nutshell. We'll kind of go through some cases maybe that'll help make this stick. So say we've got a 30, we'll go 32-year-old, and their glasses prescription is a -2. They've got a normal cornea. All their testing looks good that you talked about, Kristen. They're normal, they're not outside, they're outside like a normal person. They kind of work an 8 to 5, stuff like that. What's your kind of first procedure that pops into your head, Kristen?
First thing that pops up to me would be LASIK. -2, that's a perfectly low prescription, well within what LASIK can correct. Um, and the age of 32, so that patient should only be needing a correction for distance vision. So we don't have to really worry about bifocals for another 10, 15 years down the road. And with perfectly normal testing, that would be my first recommendation for a patient. Limitation with ICL, that is actually on the lower end of what an ICL power comes in. So I believe -3 is where you're entering the ICL range that it can correct. So given the testing is normal, LASIK would be my answer.
Yeah. Daniel, what would make you take this -2 patient and say, hey, LASIK, LASIK's good, but PRK is maybe the best option for you?
Yeah, so PRK is similar to LASIK in that except we don't make a LASIK flap. And so it doesn't remove or alter as much tissue in the cornea. So someone with an incredibly thin cornea that wasn't a good candidate for LASIK, maybe someone who was in a extreme contact sport like a kickboxer or something like that, that might push you slightly towards PRK as opposed to LASIK. And I think, all of these procedures are incredibly technical, like you mentioned, Mike. So I think, they're quick, but it's important to go to a place where you have at least all the options presented, and a place that does a lot of all the options, because it is important that, those surgeries are done frequently so you can feel confident that the person who's doing them has experience with the really technical intricacies, like you mentioned, of working in someone's eye.
Yeah. And so let's take that same patient. They're 32 still, but their glasses prescription, they're -7. And they've got 2 diopters of astigmatism. Kristen, now what shifts for you?
Yep.
Still within
So
the parameters of LASIK for those listening. LASIK goes from about +6 to -13, I believe, and it can correct up to 5 or 6 diopters of astigmatism. So well within that range. But Kristen, so they've got a couple things on table, but what's their best option?
yeah, so this is where we really rely on the technology that we have at our practice for the best and most accurate tests of the front part of the eye. And there's a couple other measurements too. Given a normal corneal thickness, is that what we're assuming still?
Yep, yeah, normal everything. Good,
Yep.
deep, normal shaped eye, deep chamber.
Yep. So given that prescription, that pushes me more towards the ICL range personally. We're able to do more nuanced calculations and to see, to the micron essentially, like what's the shape of the cornea going to be after a LASIK procedure. And I often rely on those calculations to offer my best recommendation for a patient. For me, a -7 with the -2 sill, that leads for me more towards an ICL. You could probably, given calculations are safe for both, you could present both. And I think the pros and cons there is if you would ever need, given the higher amount of astigmatism, you still have a low likelihood of needing further enhancement. But if you're doing a higher treatment to begin with, that may or may not be an option in the future. Versus with an ICL, you can actually forego treating the cornea and have that astigmatic correction from the get-go. And then, like Mike mentioned, the ICLs have astigmatic correction, but say if you do heal with a little bit of prescription that needs to be fine-tuned, that can easily be addressed with LASIK safely.
Yeah. And one thing we didn't touch on with ICL is they are reversible. So if you ever, you put it in and for whatever reason, patient says, no, I want to go back to, glasses, then you you can take it out, but it doesn't alter the shape of the cornea, which I think is the biggest thing. And so, yeah, you nailed it. LASIK, ICL, both good options for this patient, but maybe we swayed the needle just tips a little bit towards ICL. Daniel, now this patient's a -7, 2 diopters of astigmatism, wears their contacts, but also needs cheaters, so they're carrying 2 things around with them all the time. Or when they're at home, they got their glasses and their bifocals, and they're like, "Man, I'm sick of." They come in and they're like, "I'm sick of contacts. I don't like my readers. Can I have LASIK?" How does that conversation go? 52-year-old.
Yeah, typically this patient, they can have LASIK, but LASIK would only accomplish traditionally only one of their goals. You know, if you set both eyes for distance, you would correct their distance prescription and they wouldn't need glasses at distance. Now, they would still need glasses for anything up close, so you've only gotten them out of glasses half the time. You know, in the older days, we were doing more LASIK monovision, and for some patients, that's still the right option. And monovision is where one eye's for distance and one eye's for up close. But most people in that situation would do far better with doing what's called an RLE, assuming, you know, the retina is healthy that we already talked about, where you replace that lens and give them all the distances with a single surgery. And both eyes are able to work together. Their eyes, you know, don't have any sort of difficulties with balance or double vision. And so oftentimes in that sort of patient, the best situation would be to do an RLE to get them fully out of glasses. And that's assuming their retina and everything else is totally normal. And we've done a really thorough exam with thorough testing to make sure that it is a safe procedure for them.
Yeah. And so we'll get to the end here and wrap things up, but LASIK, both eyes can be done same day. PRK, both eyes done same day. ICLs, both eyes same day. RLE, refractive lens exchange, both eyes same day. Guys, this has been great. Parting comments that you want to give, Kristen? Last thing you want people to stick in their brain as they're wrapping up their drive home?
Yeah, I think a lot of patients have anxiety around, you know, people being in and around the eye, a laser being around the eye, someone cutting into the eye. And so I think it's also important to note from like a procedure standpoint is, you know, for LASIK or PRK, you know, the eye is anesthetized topically. The recovery is different between both surgeries, but during the procedure itself, painless. Same with refractive lens exchange. You're also given medication to help you be relaxed and comfortable. You probably may or may not remember the procedure is what I kind of educate patients on. So from like a psychological standpoint, there's a lot of anxiety surrounding the eyes, but just to know we also have the surgeons here that are able to make sure the procedure is done comfortably too. It really helps patients feel at ease too.
Yeah.
Yeah, I
Dan?
would just say that, you know, there's a lot of options. I think that's what we've tried to get at today is there's a lot more than just LASIK. And so it's important that you have those options presented to you and you've had all the testing to make sure whether you're a good candidate for one versus the other, depending on your stage. You know, and we're happy to do that testing. We have online scheduling. So, you know, people can easily get in and make an appointment with us, whether that's calling our phone or scheduling online. And we can do all that free testing for you to see if you're a good candidate.
Yeah, I totally agree with you guys. You want to go somewhere where you can get a full exam, lots of testing. As Kristen said, don't be nervous about it. You know, let us put you at ease. We'll do all the hard work. We've done all the training, we've done all the surgeries. We'll go through, give you the different options, let you know what's going to be best for you, and make sure you can live your best life with your best vision, distance and near, and everything in between. So thank you all for listening and learning more about refractive surgery outside of LASIK with ICLs and RLEs. If you're interested in learning more, book a consultation with us. You can give us a call. You can go online, vancethompsonvision.com, book something up, and we'd be happy to see you. Thank you guys so much and hope you're having a wonderful time.
Thanks, Mike.
Thanks, everyone.
Got it.
Thank you for listening to Clear Answers About Clear Vision, the exclusive podcast by Vance Thompson Vision. We hope this episode has empowered you to take the next step toward achieving clear vision. If you found this information helpful, please share it with a friend who might benefit too. Ready to take the next step? Schedule an evaluation with our expert team or visit us online at vancethompsonvision.com to learn more. Together, we'll help you see the world more clearly, one decision at a time. Until next time, take care and keep your vision worth seeing.